So I just want to kind of go through a timeline of how we got to transplantation as being a really viable treatment for management of end-stage heart disease. The first heart transplant, as you know, occurred 51 years ago in December 67, performed by Christian Barnard in South Africa. And this is the first recipient, Louis Washansky, who unfortunately only survived 18 days. And really, it's because of our poor understanding of the immune system at that time. He was overly immunosuppressed and unfortunately developed pneumonia and succumbed to that. Really, the father of transplantation is Dr. Norman Shumway, who performed the first adult heart transplant in the United States at Stanford in January 1968, and also trained Christian Barnard to perform the procedure when he was a fellow at Stanford. But when it comes to the immunology of transplantation, arguably the father is Sir Roy Calm. Sir Roy, in 1962, demonstrated efficacy of azathioprine in preventing rejection of renal allografts. In 1971, cyclosporin was isolated from a fungus, and it was shown to demonstrate selective immunoregulation of T cells. Well, he took an interest with this compound, and in 1978 showed that in orthotopic heart grafts in pigs, survival could be increased from a mean of about 5.7 days to more than 68 days. And this really was a watershed in immunosuppression for solid organ transplantation. However, its early use was limited by poor GI absorption and toxicity, which was subsequently addressed by the development of a microemulsion oral preparation and the development of radioimmunoassay and chemical assay for detecting serum levels of the drug. And in this graph, you can see that median survival in heart transplantation really took off in the early to mid-80s following the introduction of cyclosporin, although there are a bunch of other drugs subsequently which have really made an incremental impact in improving median survival. And not to really belabor the point, but the advances in surgical techniques have also led to significant improvement in outcomes as well. And as a result, the number of heart transplantations really skyrocketed in the mid-80s. There was a bit of a lull in the early 2000s because of donor limitations, particularly in the United States and Europe. But you can now see that there's actually an uptick in transplantation in the last few years, and most of it is in this red graph, which represents nations such as India, where there's an exponential increase in the number of transplants, and this includes South America as well. And similarly for lung transplants, there's been a really exponential increase in the number of procedures being performed since the mid-80s. And this is a recent publication in the Hindustan Times, which showed that heart transplants were picking up in India with a 10-fold increase in since only 2016, nearly 300 transplants performed across in 2 years, according to data provided by Noto. Well, I mentioned the improved survival with the advent of immunosuppressive therapies. What is the data? A number of randomized clinical trials have been performed over the years, and this really table kind of summarizes what we found. Our group showed that MMF was superior to azathioprine in terms of improving survival. We also subsequently showed that it may be beneficial at reducing allograft vasculopathy. Howie Eisen in Philadelphia showed the benefit of everolimus causing less rejection and also being beneficial in terms of allograft vasculopathy. both European and US trials comparing cyclosporin and tacrolimus showed that tacrolimus was better at preventing recurrent rejection than cyclosporin. And daclizumab was shown to lead to less rejection as part of a primary endpoint, but unfortunately was also associated with a higher mortality due to the clinical trial design. And if we look at survival by era in the ISHLT database, we see that there's a significant improvement in both heart and lung transplants by decade. And this really reflects the improved post-transplant monitoring, surveillance, and treatment that we've come to appreciate. We've heard a lot about antibody testing, and really Dr. Terasaki, who was the director of the UCLA Immunology lab for many years, before going out and venturing into developing and commercializing the test that we use so commonly. And the development of these solid phase assays have really been a game changer in our ability to more accurately define immunological risks using these tests. So we know that elevated antibodies are associated with poor outcomes. And you can see here that just elevated pre-transplant PRA without knowledge of donor-specific antibodies, we know that if you're sensitized, you're going to have either more rejection or poor survival. In most cases, there's good data to show that there's more rejection, although with appropriate treatment, survival is not significantly affected. However, if you do develop de novo donor-specific antibodies after heart and lung transplantation, then there is a problem, and a lot of patients do develop antibodies. And you can see here from data from the United Kingdom that about 25% of patients at 10 years develop some form of de novo donor-specific antibodies to their allograft. And if they do develop it, then they're more likely to have an adverse outcomes in terms of survival. And with regard to the lung transplant literature, the development of antibodies is associated with both rejection and the development of bronchiolitis obliterans syndrome. So antibodies, unfortunately, are still going to cause problems in our field. What about rejection monitoring? Well, the endomyocardial biopsy has really been the cornerstone for detecting rejection. Problem is, it's an invasive technique. There's a finite risk for infection, tricuspid valve damage, bleeding, transient arrhythmias. And even, unfortunately, amongst expert pathologists, there's only a 67% concordance to identify rejection within the biopsy. There's also the issue of only being able to assess part of the myocardium and missing areas that may have active rejection. So there is an unmet need for a reliable, non-invasive test to detect heart transplant rejection. And the intrinsic problems with the pathology approach is that the definition of lesions are based on expert consensus and not on clinical outcomes. Grading is modeled on morphology, what you see, and not on functional or pathological evaluation. So we may see lymphocytes on the biopsy, but we don't really know what they're doing. Are they causing cytotoxicity, or are they just innocent bystanders? And traditional histological methods, as I mentioned, really show poor concordance for grade 2R or greater rejection due to equivocal findings from old biopsy sites, quilty lesions, and even infections within the myocardium. So what are the newer techniques for detecting antibody? The AlloMap test was developed looking at a performance of 40,000 genes, and 20 genes were identified, 11 of which contribute to a score and 9 for housekeeping. This has now become a fairly standard test in the United States. It is a test that has a high negative predictive value. In other words, if you have a low score, then you're pretty confident that the patient doesn't have cellular rejection. But if the score is elevated, it doesn't necessarily mean that the patient has rejection. It just means that you have to do a biopsy. There are limitations to the test that you can only use it for more than 55 days post-transplant, and when your prednisone dose is less than 20 milligrams a day. It's not validated for antibody-mediated rejection, and if you've had a blood transfusion or erythropoietin or a Neupogen within 30 days, it's hard to use the test, and it may not be reliable in recent infection as well. It is a test that's only used for surveillance and has absolutely no role when you suspect acute rejection. You still have to do the biopsy. Another modality that we've been looking at is the cell-free DNA test, which is essentially looking for donor-derived cell-free DNA within the blood sample. The allograft spills DNA into the circulation simply from turnover of cells, and there is now data to suggest that monitoring this may be a good way for monitoring rejection. And certainly, if you have an episode of rejection, you may see more donor-derived cell-free DNA in the circulation. And we've been participating in the clinical trials with this test, and clearly there is a signal to show that that increased donor-derived cell-free DNA in the blood correlates with biopsy-proven rejection in heart transplant recipients. And moreover, the increase in cell-free DNA tends to even show up about 1 month before clinical rejection. So you may be able to see whether the patient is about to develop rejection or not using this test. And this test also may be useful for monitoring response to rejection, in that if you treat a patient, cell-free DNA levels actually decline fairly quickly post-treatment. So a blood test that may be useful in really monitoring this much more closely. This test is currently being used in conjunction with the AlloMap test, and will soon be marketed in the United States as the AlloSure test for monitoring allograft rejection non-invasively. Another approach to try and improve the performance of the biopsy is molecular phenotyping. This allows the possibility for an increased accuracy in diagnosing and treating pathological states by relating gene expression to the disease states. And a system has been created to diagnose pathologies within the heart, allograft by Phil Halloran at the University of Alberta. This system has been used for identifying T-cell mediated rejection, antibody-mediated rejection, and even acute kidney injury in the kidney, and it has also been evaluated in both heart and lung transplants. It's called the molecular microscope diagnostic system. And what it's done is that it looks for molecular expression for certain transcripts that may be involved in the T-cell pathway or the antibody-mediated rejection pathway within the biopsy. So you still need to do the biopsy, except you're going to do a molecular analysis on that biopsy. And the pathways that have been looked at are for CTLA4 signaling, T-cell receptor signaling, dendritic cells, natural killer cells, and on the antibody side, natural killer cells, endothelial cell activation, interferon gamma, and leukocyte endothelial interaction pathways as well. And the type of report that we get from these assays using performance characteristics is a statistical value that tells you the probability of the patient either having no rejection, antibody-mediated rejection, or T-cell rejection as well. And this is an example of a patient of ours who presented with clinical rejection, underwent a biopsy, had nothing showing on the endomyocardial biopsy by histology, but the molecular microscope was highly suggestive of antibody-mediated rejection, which is consistent with the presence of donor-specific antibody in the patient. And we've evaluated the performance characteristics of this test in 31 samples, of which we had agreement in 20 patients. 13 had no rejection, 2 T-cell mediated rejection, and 5 antibody-mediated rejection. There was clinical agreement with the molecular microscope in 9 patients. In 2 patients, there was no agreement, but in those cases, the molecular microscope was negative, the biopsy was negative, and the patient had no DSA, and it is likely that this represented possible chronic injury. And the overall agreement we had was about 94% with biopsy and the molecular microscope. So this is certainly a very interesting approach to having a deeper dive into what's going on at a molecular level in patients undergoing allograft rejection. The future applications of this test is that the diagnosis can be made with a single biopsy core. It could improve our histological interpretation. Automation is possible. Results are quantitative. We can gain insights into the pathologic processes. We can personalize the approach to therapies by actually determining which pathways are activated and specifically focusing our treatments to those pathways, and may be the potential new gold standard for rejection detection. It has been extensively evaluated in heart, lungs, and kidneys, and has been applied to all 3 organs. I just want to finish off by talking about something that's really way out there, which is xenotransplantation. And Norman Shumway always said that the xenotransplantation was the future of cardiac transplantation and always will be. Well, perhaps this may not be the case. This is being touted as the potential solution for donor organ shortage. There would be an unlimited potential supply of organs. The procedures could be performed electively, so surgeons no longer have to get up in the middle of the night. I think that would be very popular. The immunologic barriers remain the most significant hurdles to successful xenotransplantation. It's really complicated by the presence of natural anti-pig antibodies that bind to galactose alpha-1 and 3-galactose or gal pathway molecules, as well as 2 other antigens, the N-glucosyl neuraminic acid and SDA. These are all sialic-based proteins on cells within the allograft. However, there's been significant advances made, particularly in the pig kidney graft survival for in xenografts, and this has basically been possible by gene editing. CD55 is an organ source pig genetically modified to express the human complement regulatory protein or decay accelerating factor. In conjunction with this, there's now a pig model of a GTKO or a gene knockout pig that does not express the gal antigen. And in combination with these 2, it's been shown that you can really significantly improve kidney graft survival in a xenotransplant non-human primate model by to over a year. So what's really made this possible is the CRISPR-Cas9 gene editing technology, which allows rapid production of pigs with multiple genetic modifications that may have an impact on developing newer models for xenotransplantation. The techniques are now available whereby even porcine endogenous retroviruses, or PERVs, which have been of some concern of transmitting disease to the human population, could potentially be excluded from the pig using these genetic editing technologies. And with the use of novel immunosuppressive and anti-inflammatory agents, pig to human kidney transplantation is being planned within the next couple of years. So in summary, heart and lung transplantation are the therapy of choice for select patients with end-stage heart disease. Overall, over the last several years, outcomes regarding survival and rejection have improved substantially, and this is really based on our improved knowledge of the immune system and how to target that immune system to tame it. The use of non-invasive blood tests to detect rejection appears reliable and to avoid heart biopsies in select patients. The future of thoracic transplantation will rest on our further understanding on the genetic and molecular science of cell-free DNA and intragraft messenger RNA transcripts, and further understanding of preservation and circulating antibodies. I'm happy to take questions. Thank you.